Again, my name is Leslie. I am the marketing representative for Rothman Orthopedics. I'm going to introduce Dr. Michael Molter. He is a physiatrist with us here. We call it PM&R, Physical Medicine and Rehabilitation. Dr. Molter sees patients out of our Washington Township, New Jersey office location. He is part of our non-operative spine team here at Rothman. We are very lucky to have him, and I'm very excited to show you this special feature that we've done. So Dr. Molter is going to share his screen. At this point, he will show you a PowerPoint presentation, and at the conclusion of his presentation, we've actually pre-recorded a tour of our Epidural Suite, which we will show you. That's about 9 minutes long after his presentation. So I will stop talking now, and I will let Dr. Molter take it from here.
This is all new to me, this whole thing here. So it's weird, I'm just talking to a screen as opposed to a group of individuals. So first of all, I want to thank everyone for coming online here. This is kind of a different way to do lectures these days while we're still trying to keep folks updated on what we're doing. You know, basically my audience for this one is you guys out in cyberspace and then my family here. So again, I know you guys have many other things you could be doing, but I appreciate you tuning in, if you will, for this lecture. And the whole reason I'm doing this talk today was more to give patients a sense of what is going on when you're going to have an injection. You know, with any medical procedure, there's always some anxiety, and you know, you're not exactly sure what's going to happen or what to expect. And you know, with the internet the way it is now, you can go on there and see tons of things that are going to put the wrong thoughts or wrong ideas in your mind. And then you come in with a preconceived notion of what's going to happen, where it actually, most of the time when patients come in for these injections, when we're done, they say to me, that's it, really, that's all it was. So that's why I wanted to do this, was just to give you a little basics of the injections and then kind of show you around what you'll see on an injection day and go from there. So I want to thank you all for, again, not only supporting Rothman, but, you know, coming and seeing us. A lot of these patients we've been seeing for a long time, and even through all of the virus stuff that we're dealing with, we really appreciate you just not only just coming for this talk today, but continuing to come into our office on a regular basis. So I'm going to bore you with a little bit of statistical stuff here. Basically, when we look at the amount of back pain that we see as a percentage, there's a wide range, but usually greater than 50% of patients sometime during their life are going to have some form of back pain. Now, that doesn't mean everybody's going to have a herniated disc and sciatic base pain. It just means that you'll have some form of back pain. And the number of dollars that are spent on this is astronomical, and really a large amount of it is due to the work-related losses that we see, whether it's lost wages, patients being out of work, whatever it may be. That is a large percent of this. And so when we talk specifically about the pain down folks' legs that they get, the incidence of sciatica is a wide range, up to 40%. And 90% of these are due to a herniated disc. But there are also types of pain down the leg, or what we call radiculitis, that are not from a disc pushing right on a nerve. They can be that there could be inflammation around the nerve, or what we call an inflammatory radiculitis. So radiculitis is just the term we use for the pain down the arm or down the leg that you get from an irritated nerve. Another thing I want to bring up on when we talk about sciatica, it's a term we tend to throw around loosely with this, in that talk about the sciatic nerve, but really you can get pain at different parts of your leg that are not from the sciatic nerve specifically, but from different branches within the lower back. So we use the term sciatica, but you know, the sciatic nerve really runs down the back of the leg and then splits and then goes down into the lower part of your leg. But it doesn't cause you pain in the front of your legs or in different parts of your legs. So that's why we treat different levels of the nerves in the back, as opposed to just addressing, quote unquote, the sciatic nerve. And so why do we treat these conservatively? And the reason behind this is most of these are going to get better with conservative treatment. And it's really, you know, the number is not exaggerated. It's about 90% of these disc herniations that will get better on their own. And why that is because when that disc is herniated into the space where it's not supposed to be, your body sees it as a foreign object. Kind of like if you have a splinter, and that's kind of the example I use, and that your body will try to get rid of that. Your body will try to shrink this disc on its own. And there's really no time frame for that. I can't look at your MRI, predict and say it's going to get smaller over 10 months or 12 months. What I can tell you is you won't have pain for as long as that takes for your body to heal there. Now, so when we're talking about the disc healing on their own, you know, I tell patients that it's basically a time frame that this has to go through. And, you know, the tough thing is you come in and you're in a lot of pain, and I'm going to sit here and tell you, well, this disc is going to heal itself on its own. I can't tell you how long, but it will heal on its own. I can get the frustration with that there, but the reality of it is that's what should happen. And, you know, we have the statistics to prove that. Now, we're talking specifically about disc herniations here, but there could be a number of reasons why you will get this pain down the leg from wearing down of the disc, or what we call degenerative disc there can cause some of this as well, all of which can cause, again, with the term we use, radiculitis there. So some of the conservative treatment, again, I know we're focusing on the injection part of this, is physical therapy, whether it's land-based therapy or water-based therapy. Medications, not really a big fan of putting folks on a bunch of medications. You know, the injections, which we're obviously talking about, and the bracing and modalities such as stimulation there. None of these will speed up the healing of the disc. And you're going to hear me say that a number of times, because patients say, well, the injection is going to shrink the disc. It doesn't. That goes back to your body being able to heal that disc on its own. So that the treatments that we're doing are all things to try to help get us to that point where the body is healing that disc. All right, so injections are great. They work well. They get rid of the leg pain. Why can't we just start with them to begin with? Well, there's a number of reasons why we don't do that. First of all, you have to have additional imaging before you can even consider doing an injection as far as the lower back is concerned. The other is that medications and shots both can help with pain, but they're not the long-term solution. I can't argue when somebody says, can you put me on this medication or do this injection to lessen my pain? And the answer is yes, it will. But the reality of it is, of the conservative treatments we do, the thing that's going to help you long-term is the physical therapy. That's what's going to help strengthen your back and your core and lessen the pressure on the discs and things to that effect. So that's what's going to help you long-term. You know, it's kind of the old adage, you have to put the work in to get the success there. So that's why we tend to emphasize this conservative stuff more so in these situations, because there is an endpoint where we know that things will improve. So now we've decided to have an injection. So what's going to happen? Well, first of all, the patient and I are going to meet in the room during a regular patient visit and go over what we've done so far as conservative treatment care. Did we try physical therapy? Was the pain too much to actually do the therapy? Did it not work for you? Are you still having the same symptoms? The medications, did we try? Did they not work for you? Did you not tolerate them? Again, did we have the appropriate imaging done? When we're talking specifically for epidural injections, it's really either a CAT scan or MRI, depending, that will allow us to get a better image of the spine going into an injection. We will not usually do injection in the lower back without some form of what we call advanced imaging. As far as other injections, such as hip joint injections or sacroiliac joint injections, typically x-rays are fine for that. We don't usually need an MRI or a CAT scan unless we've done a prior injection and things really haven't gotten better. Then we have to look at why things didn't work as far as the injection is concerned. Discussing the specific injections there, in which we'll get into this a little bit later, there are specific types of injections that we do as far as based on where your pain level is and where your pain is. As far as the level in your back, is it going down the leg? Is it just localized in the back, or is it just in the hip? So all those come into play in us discussing this, because there's not one injection that fits every patient. So it's definitely a patient-by-patient thing that we go through looking at this. The risks and benefits of the injections. Why I bring this up is, if I have someone that has a significant heart history, is on blood thinners, and has had strokes, us taking you off of those blood thinners that you need to, for that instance, the risk may not outweigh the benefit as far as this is concerned. So that's really one aspect of it. The other is, if I have someone that's a diabetic, there we have to make sure their blood sugars are controlled so they don't become significantly elevated and out of control when we do the injection. The next line is pretty important here. the injections have to be consistent with the exam and the imaging results. And what I mean by that is, and this is something I will tell patients all the time, is that we don't treat pictures in the office. We treat patients. So if you come in with an MRI and it shows that you have a large disc herniation at the level above where the nerve is running that should be causing your pain, we're not going to do an injection. You can have the worst looking disc herniation in your back, and if it's not what's causing your symptoms, we're not going to do the injection. And that may sound like an obvious statement, but I try to emphasize that to patients on a regular basis there. So now that we've met you in the exam room, the next step is I will have you fill out some paperwork, and then we will take you to meet with our schedulers. And they really are the backbone that gets all this done, because they will get the certification for the procedure for you. You don't have to worry about any of that paperwork. They also set up the time for the injection that works for you as well. They, in addition, will obtain other clearances. And what I mean by that is this. If you're on blood thinners and the procedure we're doing requires you to have some alteration in changing that or stopping it, they will work with your prescribing physician as far as a safe stop and start time for that medication. You cannot just go off your blood thinner on your own and then come in and have the injection without a clearance. We won't do that. It's not safe for you. You're putting yourself at risk with that. And the other thing is with the clearances, if we have someone that's blood sugars are slightly unstable, we want to make sure they're not at a significantly elevated the day of the injection, because we want to make sure that we're not going to raise those significantly. So I put up this picture because for two reasons. One is I wanted to show the actual disc herniation here where this arrow is on the slide. And why I bring this up is to show you that when this disc is sitting in this white space here, basically that is the space where it's not supposed to be. So when your body sees that, this area then will try to shrink this disc. And that goes back to the fact that the disc will shrink on its own over time through your body doing that. So that's why I bring this slide up. The other is that if your nerve is not the one being pinched at that level, we're not doing the injection. So again, we want to keep that into consideration there as well. But the interesting thing when I tell you is there's two discs on this slide. This one is much more likely to get better and smaller than this one because it's larger and sticking into more of that space. And it's also more likely to be causing you more discomfort. But again, if we can get past that point, then that's what we look to have the body healing it on here. So the epidural injections, basically, they're designed not for everyone. There's a select group of patients that will get short-term relief for the injection. I never tell anybody that the injection is going to give you lifetime relief. That's not how they're designed to work. And not every candidate is, again, has the same injection or needs the same type of injection. A lot of that depends on where their pain is. The injections, as I mentioned, along with the physical therapy or medications, folks tend to like to call it a Band-Aid, but my term I like to use is it's a bridge. So basically on one side of the river, you have this disc that's sticking out into this space. On the other side is you have the knowledge that this disc is going to heal. So what the injections and medicines and therapy for is they act as a bridge to that. They're to lessen the pain and to lessen the limitations that you're getting from the pain that you're having from the disc. So that's what we're trying to do, so get from one side to the other. As far as leg pain versus spine pain, when we're talking specifically for epidural injections, they are much more commonly done for leg pain than back pain. Do we do them for back pain? Only in patients that have had the full course of conservative care without much relief. They really have been found to help much more with leg pain. Now, depending on the type of back pain that they have, there are different types of injections that we can talk about that I'll bring up later. In regards to, does surgery help, or the injections help lessen the need for surgery? There's really not been evidence one way or another that happens. As far as the approaches to the injections are concerned, there's a number of different types. One is called interlaminar, the other is called transforaminal. And this is specifically for the epidural injection. And the name is for the area where the needle is placed. And I'll show you some pictures of those in just a little bit there. Again, one more time, the interventional procedures, we're not going to change the anatomy with these procedures. Your body has to heal it on its own. Therapy is what's going to help strengthen that area in your body itself. They're done with x-ray guidance and contrast administration. Now, if your patient has an allergy to contrast, then they may need a prep for that. There are some injections we can do without the prep, but most of them we do need some form of prep there if there is an allergy to the dye. We can also use a different type of contrast. One thing I'll bring up with the contrast is it used to be believed that people that had a seafood allergy had an allergy to the contrast. That's not the case. They're different proteins. So the one type of allergy does not mean you're going to have an allergy to the contrast itself there. And again, they do not speed up the healing process here. So we've had all the conservative care. We were unable to tolerate the care, whether it's therapy or medications that did not help. So then we go on to the injection. So the type of injections we're going to talk about just briefly. Again, one is the epidural injections, which are done primarily for leg pain. If we're doing them in the neck, it's primarily for arm pain. Joint injections and aspirations are done for patients that have pain within the hip or other joints, usually to relieve the discomfort there. Occasionally, we will aspirate those joints. If it's somebody that's had a hip replacement that they're trying to rule out infection or other things, we can do an aspiration of that. A lot of times, some of the joint injections will be what we call a diagnostic injection, where we're just doing an injection of numbing medicine to try to see if that's the source of pain. Facet injections, basically facets are basically joints that are between the vertebrae and your back. And they're joints just like your knee, your shoulder, your elbow, except nobody talks about them except spine doctors, but they help provide your spine with stability. They will usually be a cause if someone's having a lot of what we call axial pain or just pain in the back themselves. The reason I bring this procedure up is this is one of the most common questions I get when I see a patient is, can't you just go in and burn the nerve? And this is where that subject comes from, because the facets have their own little nerves that we can do nerve blocks on. And if you get relief from them, then we can go in and do a process called an ablation. An ablation is when we take a probe and go in and burn the nerve that goes into that joint. Now, you can't do those for patients that have sciatica because those are the big nerves that go down your legs. But why we can do that procedure for the facet-based pain is because those nerves are localized to those joints. And again, that tends to be primarily for back pain, more so than for leg pain. So the interlaminar injection, basically, again, these are talked about based on the location of the needle. And so the lamina is this back part of the bone that makes up the vertebrae. So what we're doing is going in between, or interlaminar. The injection that you're seeing here is the needle is placed between the 4th and 5th vertebrae. And the spinal cord ends higher up in this level where the arrow is there. And so when we do this type of injection, unless you've not stopped your blood thinners, there's really a very minimal risk of any type of being paralyzed with this. When I talk to patients about what they're going to feel, and you may see some of this in the video, what you're going to feel is pressure. And why you feel that is the epidural space, the way I describe it to patients, it's kind of like a balloon. So if you imagine you have a balloon and you put a needle in it, it's going to release pressure. And that's what happens when we do the epidural injection. And so when you feel that, you may feel the pressure in the back, you may feel a little bit of pressure down the leg, one side or the other. If you don't feel that pressure, if you don't feel it down the leg, that doesn't mean the injection's not working. So, you know, there used to be people tell, well, I didn't feel it, so it's not going to work. That is not the case whatsoever. So the next type of injection is the transforaminal injection. Now, the difference is, again, is basically where the needle is placed. So the needle in this case is placed right where the nerve is coming out. And these injections tend to be much more successful for folks that have specific levels of disc herniation and the radiculitis or nerve irritation down one part of the leg there. They found, at least in some studies, to be much more effective than the interlaminar injection. So this is just a picture of the hip injection. Basically, we do these under x-ray because you can't just put a needle in someone's groin and say, you're in the hip joint, nor would you want me to. So that's why this is done under x-ray. They can also be done under ultrasound as well. Basically, you go right below the ball and socket here. And basically, what you're seeing is some dye that's in the joint there that we did the actual injection. So frequently asked questions. So there's a number of these that we'll go over. So the onset. So how long does it take for an injection to work? So basically, what I tell patients is everyone's different, but what we have to do is it takes time for your body to break down the steroid. So usually about 4 to 7 days or 7 to 10 days is what I tell patients. Everyone's different. You may get some relief of from the injection based on the numbing medicine, but that's not the long-term relief. The long-term relief comes from the actual steroid itself. So the other question I get is, so my back doesn't hurt, why are we doing the injection there? Because 90% of the time when you have a disc herniation, and nothing in medicine is ever 100%, it's all leg pain, not back pain, but that's where the nerve is originating from, so that's why we do the injection there. How long will it last? How many will you need? There is no way to know until we actually do the injection. I will tell every patient when they have their first injection, I can't look at you, look at your MRI and say, you're gonna get this amount of relief, it's gonna last this long, or you're gonna need more than one until we actually do it and see how you do. Is it the same as pregnant women get? And by name it is. It's an epidural injection. The type that women get when they're pregnant is a continuous epidural where they put the needle in, put a little catheter in, and they give numbing medicine in there. What we do is what's called a single shot epidural, and that's exactly what it means. We put the needle in, we get in the epidural space, we do the injection, take the needle out, and we're done. What will you feel? The most you'll feel is a couple things. One is you'll feel a little pinch and burn when we give you the numbing medicine. The second is that pressure when we're doing the actual injection. And that pressure does not last. Usually that resolves by the time you're going out of the recovery area. Can you be paralyzed? Well, obviously we do everything we can to prevent that, basically using x-ray guidance, the contrast as well. With the interlaminar injections, the risk is very low as far as the lower back injections, but with the right x-rays and doing the right imaging, we put the risk minimally. One thing that is very important in this, and it has to do with the steroids more than anything, is we have to keep track of what other injections you're getting. It's very rarely that I'm seeing somebody in the office that hasn't seen one of my partners for some other joint issue, whether it's their shoulder or their knee, and has had an injection. And there are limitations as far as the amount of steroid one can have during the year. If we're strictly talking about an epidural injection, the rule of thumb is 3 over 6 months, 4 over a year. And it's because of the steroid. If there was no steroid, we could do an injection every month, but because it's a steroid, that's what limits, is the rate limiting step, I should say. As far as consideration of surgery, I put this in here because over the last few years, there's been some question to whether doing an injection, whether it's in the hip or the back before a surgery, adds to the risk of infection during the surgery. And the results in the studies have been mixed, and the jury's still out on that. But you definitely want to check with the surgeon that you've been speaking with if you're actually thinking about having surgery as far as doing the actual injection. Seems a good time to talk about travel restrictions because we seem to talk about that a lot these days, but usually after the injection, you don't want to be doing any prolonged driving for a number of days. The other thing that I tell patients, I really don't like you flying for about 3 to 5 days after the injection. It has to do with going up in the airplane and the change of pressure there. There's been some cases where patients have had some bad side effects from flying on a plane too soon after the epidural injection. It's not common, but you also want to limit any chance of any bad outcomes. When can you get back to doing things? Well, we don't want you going home that day of the injection and going to the gym. I also don't want you going home the day of the injection just laying down. You don't need to do that. There's a medium there where you can resume some of your normal life within reason. We just have to be smart about what we're doing after that there. So side effects. There's always more than I list here, but some of the reported side effects, and most of them, again, unless it's an allergic reaction to the contrast, are due to the steroid-based injection. So a little bit of increase in pain can be noted after the injection. Again, that usually lasts less than 24 hours. Non-positional headaches, the facial flushing, and the anxiety and sleeplessness all were a result of the steroid there. They will usually resolve within 24 hours without much issue. The high blood sugar, particularly in diabetics, it's not the day of the injection that we're concerned about. It's a day or two after that when your body starts to break that down, it gets into your system. That's when we have to keep an eye on it. And that's why we go through the clearances to make sure your blood sugars have been stable. And if you are managing them, what to do if they should get significantly elevated. The biggest issue And the most painful one that can occur is a spinal headache. And a spinal headache is what happens when, even with using the contrast, using the imaging as far as the x-ray is concerned, we get into the spinal space instead of the epidural space. And what happens is you will get a spinal headache. And these are very specific headaches. They're positional headaches. So what I mean by that is they only affect patients when they get up. If you're laying down flat, usually you will not have this headache. When you get up, you will have one of the worst headaches you've had there. The good thing is, most of the time they will heal with conservative treatment. And conservative treatment is usually rest and caffeinated beverages, because the caffeine helps to constrict those vessels there. If that does not help, then we will often do what's called a blood patch. And a blood patch is basically, we take some blood from your arm and we inject it into that area in your spine there, just like you had the epidural injection. Now, obviously that doesn't sound like a pleasant procedure whatsoever, but the efficacy of them is tremendous. Usually we do it and patients feel better before they leave the waiting room. That all being said, in the practice that I've been in for 20 years, I've done 3 blood patches altogether. So they can happen, and the truism of this is the more procedures you do, the more likely you're going to run into one of these side effects or issues that come up. But thankfully, they are not that common, and when they are, usually will resolve with rest. So I hope I gave you some overview of some of the things with the injections and what to expect, and then hopefully the video will get more into that there. So I'm going to let Leslie take over from there, and I'll be watching the video for the first time with you as well, because I don't like watching myself, let alone hearing myself talk most of the time. So hopefully we'll get some good information out of the video. So again, I thank you for your time and participating.
Okay, so I'm just going to remove Dr. Molter's screen share, and I am going to share my screen. We're going to share the video, like we said, so that everyone can see a presentation of our Epidural Suite here.
The reason we're doing this video is to introduce you to our Epidural Suite, or where we do injections here in our office in Washington Township. Try to ease everybody's mind and give them an idea of what to expect when they come into the office. So the first thing you're going to see after you come in and get your blood pressure checked, the vitals done, is you're going to come into this room, which is what we call the Epidural Suite or the block suite. In the block suite, there will be 2 individuals, myself and an x-ray tech. We're the only ones that are in here during the injection. Also in here, obviously, we have our x-ray facility and the screen so we can visualize where we're doing the injection. Before we do anything, we're going to confirm that you are who you say you are, and that we're doing the injection that is scheduled, and go over any questions that you may have. And I do generally will go over the procedure again with you before we do the actual injection. Now that we've confirmed who you say you are, we've gone over the procedure. For a typical injection, as far as a lower back injection, we're going to have you lay on the table on your stomach with a pillow underneath here. The thing you will feel during the procedure is this table will go up. Once it's up to a certain level, it will not go up and down until you're done with the injection. The other part of our imaging is what we call a C-arm, and it's called that because obviously the shape that it has, but that is the part of this that will move. It will either go above you or on the sides to give us the best and most accurate picture of where we want to do the injection. This is how we use this to give us the pinpoint precision that we need for these injections. Now, while I'm talking about the C-arm, the other thing you'll notice when you come in the room is that both myself and the x-ray tech have these nice things on that are basically lead to protect us from the x-ray. Well, the reason we have these is I do these every week, numerous injections a day for years and years and years. You're not being exposed to any significant amount of x-ray any more than the x-ray you got at the office before you came in here. But we wear these because we're in here on a more frequent basis there. So I always tell patients that just to reassure them that we're not using a significant amount of radiation in here. And to make it more scarier now is we have the masks on as well along with them. So again, this is the only part of the machine that will move during the procedure itself. So the reason we're doing this is I have many patients that I see that are anxious about the injections that we're doing, and I wanted to give them an idea of what to expect before they came in to try to help ease that. Then they would have an idea of what to expect here. When I see patients in the office before an injection, I always tell them that it's just like a regular patient visit. You'll come in, you'll check in the normal way. The only difference is we bring you back to do the injection. And more now, we're doing most of our injections in the office. So going to the surgery center and having sedation and things like that aren't done nearly as much as they had been in the past, which is another reason why I like to kind of ease people into this, letting them know what we do in here to get everything set up. So at this point, once we bring you into this room, which is what we call a block suite, you've already been through check-in, you've already been evaluated by our nurse, had your vital signs, blood pressure, things like that already done. So we come in here, the first thing we do is confirm you are who you say you are and what the procedure is that we're actually doing. And again, just as we had in the visit before this, we'll go over the actual procedure that you're doing. Once that's done, I will explain to you, as I do to every patient, it actually takes us longer to get everything set up for this injection than it does to actually do the injection part. And once we're all done, most patients will say to me, that was it, we're done already, because they think it's going to be a long, drawn-out process, when it really isn't. You come in like a regular visit, you're here at the most a half hour, and it's usually not that long. So let me go back to once you come in the room, depending on the type of injection you have, will depend on the kind of position we will put you in on the table. If we're doing a regular lower back injection or an epidural injection, we usually will have you lay flat on your stomach with this pillow underneath there. We do them in this room because we have the x-ray availability. This is basically called a fluoroscopic x-ray that we use to find the position of the needle where we're going to do the injection. There's usually several different pictures that are done throughout the process, and you may notice that the x-ray camera will move around a little bit, or I may be talking to the x-ray tech during that time frame. The table usually will be at a certain height and it won't move from there, but the main part of this, which is called the C-arm, will turn around so we can get multiple views of where we want to do the injection, therefore being, or I should say allowing us to localize the best spot for them. So once we have you laying down on your stomach, we have our, which is a standard epidural kit here. We will clean and prep your back with betadine. Once we do that, we'll draw up the medications. We do that as well to allow the betadine time to dry. The patients, when we use the betadine, the worst thing is it's cold, and there's nothing I can do about that, and that usually gets people's attention more than anything else, is that. When we do a standard injection, you're basically going to feel a pinch and burn from the numbing medication that we use. But the other thing you will feel is some pressure when we do the actual injection. Why that is because where we do the injection is a closed space, kind of like if you have a balloon, you put a needle in there, you get a release of pressure. It's the same kind of thing with the epidural space. So that's the biggest thing that people will tell me when we're doing injections, is that they feel the pressure in their back or down their legs there. If you don't feel that pressure, doesn't mean the injection is going to work one way or not. It's just a sign that you're in the right space to a certain extent. When we do that before we do that part of it, we will give you some contrast to make sure we're in the right space as well with this. The whole procedure when we're doing the injection, again, takes about 5 minutes to do there. The biggest thing that patients have is, again, a little bit of the shock with the betadine and the pinch and burn from the lidocaine. But once we give you the lidocaine, that tends to numb the area pretty good. So I always tell patients this both before the injection, in the office visit, and then when they come in for the actual injection, that you're not going to have any severe, horrifying pain with this injection. That's not what to expect. And anybody that's telling you that, that's not what you should believe as far as that goes. Once we're done with the injection, we have you sit up gradually, and then what we do is take you back to recovery. You hang out there for about 5 to 10 minutes. Once we make sure you have good feeling in your legs, then you're able to go there. With each procedure we do here at Rothman, it is a requirement for our department that you have to have a driver. And that's for not only your safety, but everybody else's safety as well, as far as that goes. You always will leave here with a follow-up visit for approximately 2 to 3 weeks after the injection, so as we can evaluate where we are and see where we need to go. The other thing that I feel I say multiple times during the day to the patients we're talking about these injections is there's no way to look at your MRI and say, you're going to get this amount of relief, it's going to last this long, or you'll need more than one until we actually do it and see how we do there. So that's why we have to follow as we do. Other than that, that's kind of the basic procedure that we do here. There are variances as far as the epidurals are concerned, but the process as far as coming in, getting the injection, and afterwards kind of stays the same for all of those. So this is our recovery area. This is where you will begin and end the journey as far as getting your injection is concerned. My nurse will have come and got you from the waiting room, brought you back into this area here, where we'll have you have a seat here before the procedure. She will go over your consent and that you are who you say you are and the procedure that we're doing. We also get your blood pressure and your heart rate to make sure that is all stable. She'll also go over your medicine list to make sure we have everything correct with that. This is also where you will come after the injection. Usually we'll have you come in here, depending on the procedure, for about 5 or 10 minutes or so, just making sure that you have good feeling in your legs and everything is working the way we want after the injection. Usually we'll have you have a glass of water back here as well. Depending on when your procedure was, you may have not eaten or drank anything before the procedure itself there. Once you're feeling all right, then we will have you go back out and we make sure you have a follow-up for about 2 weeks afterwards. If there is 2 patients in the room, obviously we have the divider of the room there, but we've been trying now in our social distancing times to just have 1 person in here at a time. Usually if there are 2 people, it's just as one is going back for the injection and somebody that has just had their injection. We usually do not have 2 patients waiting here to have an injection while somebody else is already in the room there.
I'm going to ask Dr. Molter a few questions that came in on the back end here. So without further ado, Dr. Molter, a few other things that came in. Can you just reiterate the differences if someone comes to our office for the epidural injection or if they go to a surgery center for anesthesia?
Great question. So you can hear me, right?
Correct.
Okay. So the difference, there's a couple differences. First of all, I will tell you that as far as any of the lower back procedures that we do, 100% or close to that are all done in the office now. I used to go to the surgery center to do some procedures, but most of them are done in the office. And a lot of it is because the insurances are not covering the anesthesia. And what happens is, and I get where patients become frustrated with this because they come in our office, they see us, they want to have it at the surgery center and have anesthesia. So we do our part as far as getting everything approved. But the anesthesia is a separate entity from the surgery center. So they had their own bill. So they'll have the procedure, and they'll get a bill from the hospital that's taken care of, and then they'll get a bill from the anesthesia that's separate. That all being said, the difference is now, basically, if you come in the office and have a regular epidural with us, you're there for maybe a half hour. When you go to the surgery center, it's at least a 2-hour process because you have to be there at least an hour and a half before your procedure. Then you have to wait afterwards with the anesthesia. And a lot of times patients feel worse after the anesthesia there. Now, I loved the surgery center when I went there. I'm just telling you how, I see things from that. It's a much quicker process to come in the office there. And once you've had it without the anesthesia, you realize you really don't need it. Now, having people go the other way is sometimes difficult. When I've had patients that have gone to the surgery center over and over, they have no interest in not going back there. They don't want to have it in the office as much as I try to tell them what's going on. They don't want to go back there. Now, the other thing that's going on now is obviously they have to be screened 2 days before the injection as far as COVID is concerned, and then basically quarantine for those 2 days before the injection. So that kind of follows the same rules whether you're having an injection or any other type of surgery at the hospital. Basically, you have to have the test and then go in for that. That being said, it takes them longer to get your IV and everything started than it would be to do the injection. Now, I've kind of gone the other direction as far as not doing them at the surgery center. Now, there are some procedures that we have to do at the surgery center, and it's not necessarily because we can't do them at the office. It's just the surgery center has that equipment. Like if we go to do the ablation procedure, not a lot of offices have that equipment in their office. So that's something that usually is done at a surgery center. There are also some higher up nerve blocks in the neck that are only done at the surgery centers as well because of the risk factor, and you want to have anesthesia around there. So, you know, the difference in the procedure is the same, or there is no difference, I should say, is that it's the same procedure whether you have it there at the surgery center or not. It's just you're not going to feel anything when you have the anesthesia. That's not to be said you're going to wake up from anesthesia and not feel so great from that.
There are several people commenting that have had multiple epidural injections. Does that make sense to you?
Yes. So, you know, sadly, I've been in this for like 20 some years now. So when I started doing injections, it used to be we did a series of 3 on everybody. We just signed you up for 3 injections, had them scheduled over 3 months, and then we went from there. You know, and that wasn't anybody, that's just how we were taught. And then as time has gone on, basically, you know, we do one, have you come back a few weeks afterwards and see how you do. It is not uncommon to need a series of 3 injections to do that. You know, and when I talk about the number of injections you can have, that basically resets every year. So if you have no other injections and you have your 3 or 4 epidurals that year, January 1st of the next year, it starts over. And I always tell patients, if you can manage your symptoms with the injections with 1 injection a year or 2 a year, and just kind of, you know, come in and get that redone, it's better than going and having a surgery there. So having multiple is not unusual. Now, there's no scientific stuff behind this, but I usually tell patients is we'll do 1 injection, see how we do. If it doesn't help, then oftentimes I'll try a different approach to see if we can get it to work better. If we do 2 and it doesn't help, I usually will not do a 3rd. I want to at least have some sort of response from the injection, because then if we're doing the shots that are not helping, then it may not be coming from there.
Next question, asking if there is a huge difference in a iliosacral injection versus an epidural injection.
Really, the reason it's much more less involved because we're not near the spinal canal or anything like that. The sacroiliac injection is done under X-ray because the joint is very thin and small and it has a curve to it. So you can't just put a needle in there without an X-ray guidance and say you're in that joint. That being said, it's just like the hip injection or a knee injection. It's the same medicine. We're not near any nerves. We're not, nothing like that. It's just done under X-ray because of the location of the joint that we need people to visualize that on the X-ray as opposed to just doing it in the office without.
Do you ever recommend spinal cord stimulators should injections not work for people?
They're a great tool that we have that we didn't have a long time ago. The nice thing I like about spinal now obviously you wouldn't do a stimulator before an injections, but if you have someone that can't have surgery, has had a full course of injections, has already had surgery, is not a candidate for more, the spinal cord stimulator is a nice option. And the reason I like it is you could do a trial of that. So what it is a trial of a spinal stimulator is basically, it's similar to having an epidural injection. Instead of doing the epidural injection, what we do is we put the needle in there, we put 2 little wires that go up around where the nerves originate for your lower back, which is higher up than your lower back is. And basically what we do is we leave those wires outside the skin, connect them to a battery pack, we keep that all covered and sterile, and you use it for 5 days. And at the end of 5 days, we take it out. And then you tell me whether it helped or it didn't help. If it helped, then we talk about doing a permanent implant. If it didn't help, you haven't lost anything. That's why I like the stimulators is you can do that trial and say, okay, well, this gave me this amount of relief, so let's go ahead and do that, as opposed to if it didn't help, then we're not going to do the permanent. But really, it's a small price to do 5 days of that and see if because if it doesn't help, then why would you have it put in? So I do like the stimulator. It's a nice object for or a device for patients now. They're much better than they used to be. Now you can have MRIs with them as well. So they're really good in patients that have the chronic pain, that have had multiple treatments, that don't either want surgery or can have surgery.
Do you feel it necessary to give patients any medication prior to coming in for an epidural injection to help them relax?
That's a person-to-person basis. We do not, but there's probably 1 or 2 a day that I see that we have given them a Valium to take, an hour or 2 before the procedure, but typically not. It's interesting, everybody's different. I will have some patients that come in when we do the injections and they don't want me to say a word. Or now I have some patients that want me to tell them everything that I'm doing. So everybody's different with what they want to hear, what they know. You can, when you're having the regular epidural, you can see the screen. Now you're not seeing anything but the x-ray at the back. You're not really seeing what we're doing there, but that's variable. I would say most patients we do not. I don't really have an issue doing that unless they are on other medicines they could not have that.
A few more. Is there any age restrictions in general to having an injection done?
Usually I try to be, 18 or above. I usually don't like doing them in that young of patients really until they're kind of done growing and things like that. But I mean, it can range anywhere from, 18 to 100.
It seems like most of our questions about age were a few over 75, and then one person asking if over 90 is still safe for their age.
Yeah, they're all safe. Basically we do all the clearances and things like that to make sure that that's the case. But we've done, today I had a 92-year-old that we did the injection on. They do just fine. The interesting thing, and there's no scientific basis for this, but the older patients tend to do much better with the actual injection than the younger patients. I don't know if it's because they've had other things done or used to pain, but they tend to just come in and have it done and are like, well, that didn't bother me. It's the younger patients that tend to have more pain for some reason.
Is the same amount of medication injected on every patient, or will the amount vary?
It differs on the type of injection because when we do the one type of injection in the lower back, we use one type of steroid, where the other type of injection, we use a different type of steroid, and that's done primarily for safety issues there. And same with the joint injections. We use a little less medicine when we do the SI or sacroiliac joint injection as opposed to the hip injection because it's a much smaller joint. So I don't want to put a ton of medicine in that smaller joint because it's just going to create the more discomfort. So there are variations in the medicine that we do use. Most of the injections, though, will have some form of numbing agent as far as that goes. And again, that really is just short term more than anything else there. If I could just say one other thing with the actual injection, oftentimes I'll have patients say, well, how many times did you stick me? Because it felt like a bunch of needle sticks. But what you're just going to feel two. You're going to feel the numbing medicine and then the actual injection for the epidural. But we do have to position the needle. So patients will feel that and feel that it's another injection, but it's really just the two needles there. We obviously have to position it some to get into the right space, but it's really just two sticks that they'll have during the procedure.
Wonderful. A few other questions are just insurance related, so I think that will vary, obviously, based on the patient's personal insurance, and unfortunately we can't answer those over the event this evening.
I would usually just say that as long as you've had conservative care, or have a reason that we couldn't do conservative care, the injections are usually covered there.
Right.
The girls are pretty good about doing that stuff, and they've been doing it for a while, so they're pretty good at getting those covered there. And if not, we'll call the insurance and do a review with them to try to get it approved.
And Dr. Molter, as far as your partners in PM&R as well, is this procedure offered at all of the Rothman locations?
Yes. Now, some of the centers do not have their own injection suite, but most of them do there. So there are doctors at each location that do these procedures, or multiple doctors, to be honest with you. And at each place, there's ones that will go to the surgery center. I don't go to the surgery center, but there are doctors that in the Washington Township office that do go there that I would send the patient to.
Okay. Dr. Molter, thank you so much. I'd like to thank everyone for joining us this evening. If anyone is interested in scheduling an appointment with Dr. Molter, I did put a VIP scheduling line into the chat. I will repeat that number now. It is 856-335-3537. I also put the link to Dr. Molter's bio. You're also more than welcome to go to our website, which is rothmanortho.com, just to explore our physicians, our specialties. You're also able to request an appointment directly from our website there. Again, I'd like to thank everyone for joining us. We will be sending out a recording of the presentation and also the video that was shown to everyone that registered this evening. So
I just want to thank you, Leslie, for putting it together. You did all the work, so thank you. Thanks,
thank you so much. Thank you, everyone, and have a great evening.
Good, thanks.